Hello and good morning to all of you again, and thanks to Dr. Manoranjan Das and Sean for having me on this session. Sorry I'm a little late for my talk, but I was trying to finish talks elsewhere. So I'm going to be talking about anterior segment OCT in corneal disease with a slightly different concept. I'm going to be talking about how you use the OCT in surgery. And this basically is going to be talking about some of the supine OCT systems that we've been using and those that are available, how it helps in anterior lamellar keratoplasty, how it helps in endothelial keratoplasty, and what potential future you could have for these instruments. So the two main instruments that I have used in this presentation, surprising, the screen is a little small, but is the Bioptigen SD iOS and the Zeiss Rescan. The Bioptigen basically is an OCT that has been designed to be used in a patient who's lying down, whereas the Zeiss Rescan is an OCT that is incorporated within the microscope. Now both of these are expensive machines, and we were lucky to have the Bioptigen SD iOS from a grant, and we had the Zeiss Rescan only for a few days, during which we got a few nice images. So just again to go back and taking one step back and look at keratoplasty, all of you are familiar with the different kinds of lamellar keratoplasty. You have anterior lamellar keratoplasty and you have posterior lamellar keratoplasty. Posterior lamellar keratoplasty primarily DSEK and DMEK. And just again going through the different steps of endothelial keratoplasty, where DSEK surgery involves transplanting the endothelium and some of the stroma into the cornea, into the anterior chamber, and making it stick to the back of the cornea. So one of the biggest problems with DSEK surgery or endothelial transplant surgery is the fact that you have poor adhesion of the donor that you put inside the eye to the host cornea. So this is called detachment, and donor dislocation tends to be one of the major risk factors for failure of the donor graft immediately post-op. So we've actually looked at some of the factors that are important for donor dislocation and adhesion of these donors, which is published in June cornea issue this year. And here we concluded that if you have gaps that are present between your donor cornea and your host cornea, this could be a predictor for detachment of your lenticule post-op. So it's important to identify these gaps and reduce these gaps by injecting more air into the anterior chamber and reducing the amount of fluid pockets that you have. So how would you use the OCT for imaging intraop in DSEK surgery? So going through a few surgical videos, this is the initial part of DSEK surgery where you put a lenticule inside the eye, and then you just form the anterior chamber and you do an OCT here. You see that the lenticule is barely visible at the bottom of the OCT scan, right here at the bottom, and there's a huge amount of fluid in between the donor and the host cornea. So following this, as you inject air, you'll start to see that the amount of air fluid gap in between the donor cornea and the host cornea reduces to a very small gap. But this again seems to be a risk factor for dislocation. So you need to keep injecting air and massaging the surface of the cornea till you have as little gap as possible. As you see here, the gap is reduced significantly from the previous procedure. But then again, if you are unable to achieve a complete air fill, you probably need to resuture the cornea and then insufflate more air inside the eye. So once you reinforce the wound there, you see here again that the amount of gap that you have in between is much lesser. And finally, after your final air fill and you increase the pressure to a significant amount, you see that there is absolutely almost no gap in between your donor and your host cornea, which is what you want before adhesion of your DSEK graft. And this is how you would expect to see your patient the next day with a well-adhered lenticule. And this is DSEK post-op day 1 with the ASOCT, and you see that the lenticule is actually pretty well attached. One of the advantages of having an instrument like an OCT during surgery is the fact that you can actually see for sure in the different areas of your DSEK lenticule and see how well it is attached, because manually there's no way of doing that even with a slit lamp. So if you use OCT, and this is an OCT called the DSEK Rescan, where if you look at how you're using it, we're actually moving the OCT onto the cornea where the DSEK button is attached. And as we focus the cornea, you'll see that the cornea comes into focus, and you can move your OCT scan onto different areas of your cornea to look at the amount of gaps in between your donor and your host cornea, and you can decide on how much air you want to inject and how much air you want to take off, what pressure you want to leave the eye at after you finish surgery. Another additional benefit of this kind of an OCT is the fact that you can also look at the edge of your lenticule after DSEK surgery and see if it is apposing well to the cornea, and especially in cases following penetrating keratoplasty, if you're doing a DSEK, sometimes a posterior wound of the previous graft is going to raise your lenticule off the edge. So it's important to make sure that the edge is well apposed to your host cornea so that you don't have any chances of detachment. The other interesting area where this OCT can be used is in something called DMAC. And for those of you who are familiar with DMAC surgery, that's good. But then for those of you who are not, this is a small animation that I borrowed from Melissa's website, which shows you how DMAC is actually done. This is basically an insertion of an endothelial roll, that is a Desmaze roll inside the anterior chamber. And then you tend to open up this roll with gentle tapping movements. And once this roll is opened up, a little air bubble is put in between the roll and opened up completely. It's really, really important that this roll is opened up the right way. And the right way always means that the endothelium is on the outside. And once this is done, then you can put a further air bubble and open up this roll inside the eye. So how is the OCT useful in DMAC surgery? So this is the endothelial roll that we're taking into a glass tube and injecting into the eye. And once you have it inside the anterior chamber, it really is difficult to tell how it is curled. You do not know if it's curled upward or downward. So again, we use the OCT to show us that the roll actually was curved the wrong way. If you see this curl, the endothelium actually is on the upper side, but it always tends to curl inwards with the endothelium on the outside. So this endothelium actually is going to be touching the stroma. So we actually had to use a lot of air insufflation and fluid exchange to get the optimal roll. Here is what we did. Here is we kept injecting fluid so that we could flip this over. And once we could flip this over, we kept moving it around to see if we get the roll in the correct orientation. We kept doing the OCT to see if we had the roll in the correct orientation. And finally, we got an OCT where we saw that the endothelial roll was in the correct orientation. Like I said, the endothelium is on the outside, and so if you put an air bubble, endothelium is not going to stick to the stroma, but it's going to be on the bottom side. And that is exactly how we wanted it. So this helps you to identify the correct orientation of the DMAC roll during surgery. And so following this, what we were able to do is use an air bubble to open up the DMAC graft over the iris, and then finally put an air bubble to make sure that the Desmaze roll is adherent to the posterior stroma. So this is how it helps in DMAC surgery too. And this is the Desmaze that is attached. But I think the most exciting part about using the OCT, especially during surgery, is an anterior lamellar keratoplasty. This is a patient who had lattice dystrophy, as you can see from the retroillumination, and we tried to do an ALK or a DALK using the OCT. So this is the OCT after the initial trephination has been made, and you can see the trephined mark on the cornea. This is a partial thickness trephination. And after this, we took off the anterior stromal cap, and here we're using a sharp pointed dissector to see if we can reach the right plane before we inject our air bubble. And though it's not very useful to tell us at what plane you need to go with a sharp pointed dissector, because the dissector is going to block off OCT signals. Once you make a track and come back, you can make out at what depth your track is. Here you see your needle, and especially in the top OCT picture, you can see what depth you're at. And once you inject your air, you will see that you have a very nice bubble because you're very posterior in the stroma. So this is a bubble that I have got. And interestingly enough, I actually got a type 2 bubble. So you can see the bubble that is present in this video. And I got a type 2 bubble and not a type 1 bubble. And so I'll show you how we actually manage this case, where you can also see some small areas on the OCT where you can see some small separation between the stroma and the Duas layer, as it is called right now. So what we did here was we tried to open up that separation into that Duas layer space, and once we did that, we were able to go and dissect in between the posterior stromal layers and the Duas layer, leaving the bubble that you see that is there is between the Duas layer and the Desmaze membrane, leaving that bubble intact. So this is where we were at. So we were trying to dissect it, and we left the bubble that is more posterior intact, because if you expose that bubble, the chances of it getting perforated are much higher. So this OCT helped us to identify the two different kinds of bubbles, and also to identify the right kind of plane, so we could go in and dissect it, so we can actually get to a plane where we have to expose the Duas layer. And this is where we've been able to expose the Duas layer. You can see a bubble is still intact in between the Duas layer and the Desmaze membrane, and already is looking very clear. So now you're ready to put your graft back in place, but what do you do to the bubble? So we decided that instead of leaving the bubble in place, you can see the dimensions of the bubble actually looks quite big. We thought we were going to go and remove the bubble from the gap that is present in this potential area. So again, how do you do that? So what we did was we actually used MVR blade to go into the periphery of the cornea, make a small nick, and you'll see how the bubble actually disappears, and you'll see the Desmaze actually bounce back, and you'll see a very small area in which the bubble is present. And then we used a blunt dissector, basically a cannula, to move the bubble out of the area where it made a hole in the anterior part of the Duas layer. So once that was done, we removed the bubble. You can see here how the bubble actually being milked out through that small opening, and once the bubble is completely gone, now we are ready to put our sutures. So there's the bubble gone. So after that it was pretty much standard, and we did sutured DALK and completed the surgery without any problem. So basically I think the utility of the OCT, especially during surgery, is the fact that there are a lot of things that you really can't see during surgery, especially in lamellar corneal surgery. The OCT is going to allow you to see a lot more than what you imagine. So I think that's the big thing about the OCT in surgery. Thank you very much.